Hey, good afternoon and welcome to Facebook Live. I'm Dr. Bill Burr, Chief Medical Officer at CGH Medical Center. Thanks for taking the time to join me in our conversation today. So here's what we have on tap for today. I'm going to give you a brief COVID update. We're going to take some time to talk to Dr. Treviranus, who is in charge of our sleep lab and also sees sleep patients, people that have sleep issues on a regular basis. So we're going to get a chance to pick his brain about all things sleep. And then after I get done with Dr. Treviranus, I actually yesterday went to the sleep lab and did a field trip there. So they hooked me up and put all the things that you would have a sleep study done there at the sleep lab. And so that's going to be our field trip this week, and check that out too when Dr. Treviranus and I are done. So let's kick it off with, first of all, a quick COVID update. So we've had a couple patients make mention when they come into the hospital and or our clinics, hey, why do I have to wear a face mask? The governor did what he did on June 11th. And the answer is that not wearing a face mask is in play in about everywhere except healthcare settings is one of them. And so that's why we still in areas where there's public patient traffic, patient care areas, where we are wearing face masks and required to do so. So if you're asked to put a mask on, that's why. Second thing I want to talk about is the Delta variant, which is a mutation in the COVID genetic code that took off in India, and it's making more of its presence known across the world, including here in the US. So the vaccines, so far at least, are still very helpful for this variant, and particularly in keeping people out of the hospital if they get sick with COVID. So far so good with that variant, but it is more contagious and it tends to get people who do get sick. I read today where we have twice as much of a chance of being hospitalized with that. So all the more reason to get folks vaccinated and continue to get them vaccinated, and it's not too late. And of course, we also are starting to think about vaccinating everyone else in the world, because every person who gets it is a potential person who can have that variant mutate further. So I want to get this knocked down for good. But the numbers in our area are looking very nice. So Matt's going to show you our weekly numbers for Whiteside County. And as you can see, on the left there, the graph, the red is the cases this week, and the blue are the cases last week. So you can still see that our numbers continue to trend down nicely, and that's so nice and encouraging. And you can see our positivity rate's 1%. As for example, on the 14th, they reported 3 positive cases. So people are still getting COVID in our area, but it's definitely going down, and that's a good thing. So keep getting vaccinated, keep encouraging people to get vaccinated. The combination of people being vaccinated and people that have had COVID is beginning to add up. So that's a good thing. Okay, that's all I wanted to say about COVID this week. Unless you have questions, you're always welcome to send those in. And as always, when I'm asking Dr. Treviranus questions, please feel free, if you have any questions, to send those our way as well. But I want to bring Dr. Treviranus in. So without further ado, hi, Dr. Treviranus.
Hello.
Welcome.
Thank you.
All right. So are you ready for some questions?
Sure.
All right.
Where do you want to start?
And for folks who may not know this, Dr. Treviranus has been in the area for how long, Kim?
Since 1984, so
yeah,
37 years.
Okay.
It's a while.
The vast majority of Dr. Treviranus's career, he did a lot of work in the hospitals with patients that are sick and hospitalized in ICUs and had ventilators, pulmonary patients with pulmonary conditions. and some sleep. And how long has it been, Kim? Would you say the last 4 or 5 years that you've been doing mainly sleep?
Yeah, I think that's accurate.
Okay, yeah. So that's kind of his gig right now is to handle all things sleep here at CGH. So with that information in mind, let's start talking about sleep. So Kim, is there a certain amount of time that we need to sleep?
Most recommendations for adults is 6 to 8 hours. You try to keep people as close as you can in that range. Everybody's their own individual person, so it may vary, but that's a general recommendation.
Okay. And what's the deal with if you sleep more or less than those recommendations? Are there any health implications?
Well, there are studies on people that routinely sleep, let's say 10 hours or more per night. They tend to have more health issues as they age, and they tend to have a shorter life expectancy. As far as not getting up to at least 6 hours a night, again, it can cause metabolic issues and disease processes. You can affect, blood sugar, blood pressure control, and also factors of neurological function.
Okay. So let me ask you this. You don't just deal with the amount of sleep that people get, but you also deal with the quality
Yes.
of sleep. How important is quality of sleep as compared to quantity, or how much we sleep?
Well, it's very important. If you have something that is keeping you from going into your deep areas of sleep, like N3 sleep and REM sleep, dream sleep, basically, it affects how well or how much restorative action, your sleep is giving you.
And tell me about sleep as we age. How does our sleep change as we get older?
Well, we tend to sleep less. We tend to spend more time in N1 and N2 sleep, which are, shall we say, shallow areas of sleep. We do less N3 sleep, which is slow wave for deep sleep. And as you tend to go past 60, 65, you tend to start losing REM sleep or dream sleep.
Okay. One other thing is cat naps. So, hey, just before we started our segment, I was just dragging, so I did like a 15-minute cat nap. So, what's the deal with those? Because it doesn't seem like I would go through all stages of sleep, but when you do those, most people do tend to feel better. And also, I'll hear some people say that they don't do them because they feel really bad after that. What's the deal behind cat naps?
It usually, if you have a nap that's 15 to 20 minutes, you're not going to get much more than N1 and N2 sleep. It tends to be somewhat restorative and restful. Rarely do people get into REM sleep before like 70 minutes of sleep. So when you take a short cat nap, you're basically coming out of shallow sleep, not dream sleep. When people are in deep N3 or REM sleep, they tend to be sluggish if they're woken up suddenly, and it takes them a while to, should we say, fully wake up and feel energetic again.
Yeah. And one thing I forgot to ask you at the very beginning, and that is just some people have thought about this. Why do we have to sleep in the first place? What's the theory that you're hearing about that?
Most of it's restorative, which means it allows your body and your organs in particular to get rest and to function better the next waking, episode or next day. In particular, you have like brain function that accumulates adenosine during waking hours. And when you sleep, those compounds are removed and taken care of.
Okay. And what I want to do next is kind of transition to insomnia. So in terms of insomnia, what are the non-medicinal treatments that you tend to recommend for your patients that have insomnia?
Well, if you can always do basic sleep hygiene, which is you tell the patient you try to limit your caffeine like after noon during the day. Any kind of exercise program will help your sleep drive. You try to avoid bright lights and natural sunlight after 4 o'clock in the afternoon. If you're outside, you encourage people to wear sunglasses. If you go to bed and you're not asleep within a half an hour, you encourage people to get out of bed, do something, be it reading, watching TV, or whatever, until you feel tired, and then try to initiate sleep again. People will often get some benefit from, white noise machines. Some people will do meditation exercises. They all have some benefit.
So when do you go down the path with patients of saying, hey, we might want to try some medication to help you with your sleep? And what are the common options that you recommend for patients, and why different options?
If you have patients that have followed most of those sleep hygiene recommendations and they have tried stuff over the counter, which is basically melatonin and or Benadryl compounds, and they haven't had any great success, you can look at pharmaceutical prescriptions. Most of them, the basic stuff, are benzodiazepines. They're in classes of tranquilizers. Usually their half-life is pretty quick. So they're designed to try to help you get to sleep. And again, you encourage people to try to get by without medications. But if you have somebody who is just not accomplishing 3 or 4 hours of sleep a night, and they've done everything else that you've asked of them and it's been unsuccessful, then you go, to a basic benzodiazepine. The ones big on the market are, of course, Ambien or Restoril or Sonata, and you see how well they work.
Okay. Yeah, and as far as those medicines go, do those tend to be habit forming? And if so, how do you kind of navigate that with patients?
Well, they are not habit forming in the sense of, narcotics, where you have a physiological dependency. They do have some psychological dependency, which basically means that in certain people, they will get to the point where they feel they can't sleep without a pharmaceutical sleep aid. Obviously, when you give benzodiazepines or sleeping pills out to people, you try to keep it short term, particularly if their insomnia is related to a recent event, illness, or a loss of a family member. And you try to get people off of that medication within a few months. Other people, it's very hard once you get them on the stuff that they sleep well without it. And again, if you think you're getting more benefit than harm from using the medication, you keep them on it.
Okay. All right. Sounds good. Next thing I want to talk about is sleep apnea. Big thing, big issue in sleep medicine. So first question is, how would someone know if they might have sleep apnea? Apart from their significant other going, hey, you snore terribly and you stop breathing during the night.
Yeah, minor little problem. Usually the number one system is tiredness. That's what brings in most people. But in addition to waking up tired and being tired throughout the day, you also ask people about waking up with AM headaches. You ask them about recent memory issues. And you also look for any significant problems falling asleep during conversations or driving, basically at inappropriate times.
Yeah. So, health risk wise, what are the health risks for someone who has untreated sleep apnea?
Well, you can probably generate any metabolic condition, be it blood pressure or heart function or blood sugar control, right on down the list. And they're all adversely affected by untreated obstructive sleep apnea. It's a wide range of metabolic conditions that sleep apnea, affects. And like I said, it's hard to see a cardiologist, be it for arrhythmias or coronary artery disease or heart failure. All of those are affected if you have untreated obstructive sleep apnea.
Yeah. So it's my understanding that, by history, most people, you have a pretty good sense of whether they have sleep apnea or not. But it's my understanding that it's still, to get the treatment that folks need, it's still necessary for them to do sleep studies.
Yes.
Okay. So let's talk a little bit about sleep studies. Nowadays there are sleep studies done in patients' homes, and then there are sleep studies done in the hospital. So what are the pros and cons to each, and in what situations do folks have home sleep studies versus hospital ones, Kim?
Home studies basically answer the question of whether you have obstructive or central sleep apnea, and that's pretty much the only answer you get out of a home study. Basically, that question covers, 80 to 90% of the people you see, particularly if they're young, middle-aged, and otherwise in good health. Hospital-based studies in a sleep lab give you much more information as pertaining to cardiac issues, neurological issues, and other sleep events or sleep pathology that can affect the quality of your sleep besides obstructive sleep apnea. If you have any significant cardiac or respiratory problem, or if you're on oxygen, those kind of people, you often extremely encouraged to have a sleep lab study because they're best served by that study.
Right. And so my understanding too is that, obviously the main treatment for sleep apnea, other than the lose weight and those type of things, is some type of positive pressure breathing machine like a CPAP or BiPAP. That with a home study, they're able to do that, but it's probably a little bit more of a crude way of figuring that out, or are they able to do that kind of titration for a home study?
Well, on most home studies, you look at how bad somebody's apnea numbers are. If they're not extremely abnormal, you can give most of these people an auto-adjustable CPAP machine, which basically means that CPAP unit calculates every 5 breaths what kind of pressure you need to keep the back of the patient's throat open and to keep airflow moving into their lungs. If somebody's home numbers, apnea numbers are bad, often you talk to their insurance coverage and you recommend that they be titrated in a sleep lab, because a lot of those people, CPAP will not control them. And CPAP's just a constant pressure. What they often need is to be moved to BiPAP, where you have an alternating pressure with your breathing in versus your breathing out.
Yeah, and my understanding is that it's part of this home study thing too, is insurance is driving some of that too, that they drive a lot of folks to have that home study done.
True.
Yeah. Okay. All right. And we just talked about that a little bit, but talk a little bit more about a CPAP machine and what makes it work. How does it help someone who has sleep apnea?
Oh, it's just a machine that generates a pressure through, a mass system that keeps the back of your throat from collapsing to the base of your tongue and shutting off airflow going into your lungs. The pressure can be manipulated according to titration studies, or like I said, you can put somebody on a auto-adjustable CPAP machine. And you can follow download numbers, which are all now put into the internet, into the cloud. And using a computer system or a smartphone, you can download how much somebody is using their equipment, how effective it is. And often you can get, on some studies, what kind of sleep architecture they're having.
Yeah, very slick nowadays, what you're able to do just, in that way. And so, I know you guys have a lot of different attachments to try to help folks to be able to tolerate CPAP, whether that be nasal or across nose and mouth. And most people, it works out. Eventually, they kind of get a hang of it and can do it. What options are there for people who don't tolerate their CPAP or BiPAP machines?
If you have mild, moderate disease, you can look at oral devices, which a good dentist or orthodontist would make. It's a device that fits inside your mouth and pushes your lower jaw out. What's nice about that, it's, not visible unless you open your mouth up. There's not a lot of equipment. The problem is they are usually only good for mild, moderate disease. You can also look at ENT, surgical procedures, removing tonsils, uvulopalatinoplasties, where they laser out the back of the soft tissue in the back of your throat. That will usually be fairly effective for people. The problem is it is a surgical procedure which can be done as an outpatient, but usually it gives you a bad sore throat healing up for 3 to 4 weeks.
I think so, yeah.
Yeah.
I know they do that, and I think when I was in training, there seemed like they were doing more of those than they do now. But yeah, it gets it done, but it also is pretty invasive to do that. So
True.
yeah. Okay, the last thing I want to chat with you about is restless leg syndrome. So what exactly is that, and how does that affect sleep?
Well, restless legs are where people, when they're trying to fall asleep, their legs tend to itch or burn or hurt to the point where it keeps them from falling asleep. Some people also have symptoms during evening hours or afternoon hours. They will usually describe it as, my legs just feel jumpy and uncomfortable. If people are felt to have significant problems with this, you can put them on usually dopaminergic medications, Mirapax, Requip, something of that order. Or there are people that are being treated with Neurontin in this day and age. And usually you titrate the amount to the point where you stop that kind of symptomatology, and the patient is able to fall asleep easier. Restless legs can be seen with certain anemias and kidney problems and certain medications, which you tend to screen for. And if you find any association, you try to treat that underlying problem also.
If you have restless leg, I assume it's going to affect your sleep cycles too.
Yes.
Yeah. Okay. Yeah, and I've for my patients at least classically, you'll have some either this once again the significant other that will say they can't sleep with that person, or they just start kicking bad, or
Yes.
say that their sheets are all ruffled up, and that's the classic restless leg.
Yes.
Yeah. Okay. We're just about out of time, but I did have one other thing I want to kind of a specialty question to ask you about. So Alzheimer's disease, a lot of those people have sleep disorders. In particular, their sleep cycles tend to get just messed up. Their night's day, day's night, sundowning, which is later in the afternoon. They start to have problems with agitation. Any recommendations or things that you do for patients who deal, or families of those patients who deal with those issues?
It's a tough problem. Most people with Alzheimer's have fragmented sleep, even though they tend to spend more time asleep. But the sleep of poor quality, and like I said, it's very fragmented. Usually most of the care is support care and trying to treat any problem with their sleep that you can treat. But other than that, there's no wonderful recommendations at the moment that, stops this, unfortunately.
So I'm hearing there's not a magic pill.
No, there isn't.
Yeah. Okay. Well, hey, Dr. Treviranus, thank you so much. It's been good to kind of talk through some sleep-related questions. And for those folks who are watching, Dr. Treviranus, do you see patients both in Sterling and Dixon? Is that right?
Yes.
Okay. Yeah. So he goes to both places and also does televisits too, if I remember right. Is that right?
Yes.
Yeah. So just keep that in mind as you think about your sleep. And if people give you feedback or you wonder, perhaps I might have some issues in my sleep, look Dr. Treviranus up. He and our sleep lab team can help you out, and they can definitely make a big difference in terms of how you feel, because most patients who have significant sleep apnea who then get treated will tell you that they feel much better once they get treated. So Dr. Treviranus, thank you so much for spending the time and being here with me today, and wish you well.
Thank you.
Yeah, and for the folks who are just so the next step here is we're going to have a field trip. We're actually going to go to the sleep lab, and the staff that work with Dr. Treviranus in terms of patients who are having sleep studies done will have a conversation with me, and they'll hook me up, and we get to kind of see what that would look like if you have to have a sleep study done, at least at the hospital. And we talk a little bit about home sleep studies there too. So I encourage you to hang on for that. And one final thing I'll just let you know is that next week for Facebook Live, I'm going to have a guest host, Dr. Young Song, our urologist here. She's been on with me before. I don't know how long ago it's been, but she did a really nice job. And she's going to guest host. And she's actually going to interview Dr. Eric Riley, who's our Department of Surgery chair, and also is our surgical podiatrist. And she's going to be talking all things feet with him next week. So I encourage you to check that out. And until then, enjoy the field trip, and I'll see you myself in a couple weeks. Take care. Welcome to our field trip for Facebook Live. I'm with Ashley. Hi, Ashley.
Hi, Dr. Bird.
Ashley is the manager for, she's on every third episode or so. I was joking with her. So she oversees a lot of different departments. And what are we going to be looking at? First of all, you're looking at me and going, what's going on here? But what are we going to be doing today, Ashley, for our field trip?
Yeah, we're going to be taking a tour of our sleep lab department.
Okay, all right. So we thought that the best way to give you a sense of what you do in a sleep lab department, what are you going to do for a sleep lab department?
Yeah, we're going to do some sleep studies.
So I'm hooked up to have a sleep study done. So we're going to go into our sleep study room just to kind of give you a sense of what that would look like if you or someone you know is going to be having a sleep study. So yeah, and then just before we go in there, Ashley, how many sleep study rooms do we have here at the hospital?
Yeah, we have 4 bedrooms.
Okay, okay, yeah. And so, and I would assume most of the time we do these at night.
Yes.
Okay.
Occasionally we'll do them during the day, not too often, but occasionally we can make accommodations for those patients that, they might work at night and sleep during the day.
Okay, good.
Mm-hmm.
Well, you want to show me into the room here and
Sure.
introduce me to some folks?
Yeah.
Let's do it. Okay, I'll let you
Okay.
lead the way. Hi.
Hi. So here we have Katie and Chastity. Katie and Chastity are both registered sleep technologists. Katie is our clinical coordinator for the sleep lab department as well.
Okay, so I'm going to be asking Katie and Chastity some questions here. And obviously I have a lot of things that are hooked up on me. And believe it or not, I know you're probably looking at this and going, oh my goodness, how are you going to sleep? I've had this on for everything for all of 5 minutes. And to be honest with you, I feel a little bit in my nose, but everything else I'm kind of like, okay, fine. I'm actually feeling a little tired right now. Anyhow, so I wouldn't mind actually lying down. So yeah, let's start from the top and we'll go down. So whoever wants to take a first crack at this, tell me a little bit about these things that are hooked up in me and what they're doing.
Okay, the ones in your hair actually are showing us your brain waves so that we can distinguish if you are asleep or if you're awake. Different regions show us different peaks in the waves so we can just map it out, the stages of sleep as you're going. And then
so talk about those different regions. So like, I'm going to kind of go like this, point to like
these in the back, they're the occipital ones. We put those on, and they pretty much, when you're awake, will show alpha. They call it alpha brainwave, but they help us determine when you're awake and asleep. When we run the sleep study, we kind of watch to see what stages of sleep patients get to.
Okay.
And these help when we're trying to determine if they're awake or asleep. So
Okay.
These are active. When everybody's in the normal, just regular stage 2 sleep, the main ones that are really busy are the central region. So these will help pick that up. We put one on each side, kind of so we can, if one becomes loose, we can always compare to the other, make sure that something's not happening, an artifact. But typically we could even just do one side. But so occipital is awake. The middle is for the regular stage 2s. When you get in those deeper stages of sleep, you'll see activity in these frontal ones. They're a little bit taller wave, and so that's usually indication. Okay. Stage 3 especially. We'll see that, and then usually after the tall ones, you'll see them go into REM stage. Some of these will be active during REM as well. Mm-hmm. But we put some on his eyes too, Chastity did, and what that does, it picks up your eye movements, because when you're in REM stage of sleep, 90% of the patients have that rapid eye movement too. It's just one more
So when you're doing this, and when you're doing the study, I'm assuming that you're going to want to document that I would be in REM sleep at least some of the time, because that's
Exactly.
part of having really good sleep, which is part of what I'll be asking Dr. Trev
Yeah.
about when I chat with him
Yep.
tomorrow too.
Yeah.
So,
And it
okay.
helps too, because then not only can Dr. Trev see the sleep efficiency on a patient, but he can tell where there might be potential of Dr. Bird may sleep perfect in stage 1, 2, even 3 sleep. You get into REM stage when your body's more relaxed. You usually have more severe apnea if you have it. So maybe it only shows that.
Okay.
So it will determine,
Right.
oh, he's only in REM,
Yeah,
or
that's a
he
good point.
starts to go into REM and then he wakes up because of this.
Because of the
So,
apnea.
yeah.
Yeah.
and that goes to the chin ones too. That helps us with the arousals. They call them arousals when you wake up or when you go into a lighter stage of sleep. So in REM, everything's pretty much relaxed. Your body doesn't move in a typical healthy REM stage. So we look at these eye movements we look at, but then we can also tell when he wakes up, he may not even wake, maybe go to a 2, but if these have tension in them, you shouldn't have tension or jaw clenching or anything in REM.
Yeah.
And maybe you sleep perfect, and that'll be an indication to Dr. Trev, like, well, he's breathing great, everything looks good, but he's got a lot of tension here, or maybe he's moving in REM. That's not a healthy REM cycle. So sometimes it ends up being
Okay.
restless, legs or REM behavior disorder. And
Okay.
And another thing that the chin wires also pick up is bruxism. So at night, sometimes when patients are sleeping, they grind their teeth back and forth, and we'll pick it up in the chin wires, which then also go into the brain waves as well.
Okay, that's interesting. And then talk about this thing that's in
This
my
is
nose.
called it's a thermistor and a PFO. So it's basically picking up how the patient is breathing. And then when there is a decrease in airflow or a complete obstruction, we'll see 0 airflow coming through. So we know then that the patient is actually having an apnea or he's having a decrease in airflow. More than likely, it's usually combined with an arousal right afterwards, because when the patient is obstructing, we'll see a couple of different things. Either the patient's going to start kicking their legs to get themselves woken up out of their apnea. A lot of times they'll kind of move their head, snore, open up that airway. They'll have a big arousal, and then they'll actually go right back into either sleep or obstructing again.
Yep.
Sure. Sounds
And
good.
when it comes in healthy, it looks like a nice little curved lines, what they look like in our office, like a hill up and down. And that's how we can determine if it's at least 20% less or a flat line if you're not getting any air. One is for the airflow, and there's 2 of them because the other one picks up temperature.
Okay.
And this little piece here will pick up your mouth air in case you happen to be breathing through your mouth and mouth
Okay.
breather at night.
Okay. All right, let's go down. Let's see here. I think I have something going on, so like here and here on my
You
chest, I have
do.
little electrodes, right?
Yeah, the snore mic is on, and that picks up snores, but that also kind of helps with the apneas because we'll see that snort at the end. We don't actually hear from there, but it'll be a line that's got a dot on it, the bigger the snore.
Okay.
Next, we put EKG ones. You can't see them, but we do watch the heart, monitor the heart rhythms, the rate, and then
So if you have some type of abnormal heart rhythm, you would pick that up.
we
during
do.
this-
We pick that up,
And
if
then
it's-
document it as well.
Yeah, we
because
document it, print off the
you know.
epics. If it's nothing life-threatening that night, we'll point it out the next day, let the primary physician know as well,
Sure.
along with Trev. Some patients we've been known to have to call and put on telemetry. If it drops too low or looks too risky, we'll call the nurse supervisor and
Sure.
Or also, like, if they don't have a history of heart, anything going on with the heart, then we can maybe pick it up and we can let the house supervisor know right away, like something might be going on with this patient. We can closely monitor him through the night, and then also let the primary physician know right away in the morning.
Sure.
Yeah.
How about these 2 straps?
those are the respirator belts or rest belts. They pick up so if it watches when you breathe. It'll pick up. There's sensors inside here that pick up any movement. So rolling, moving, chest rising up and down, stomach. These are really important when it comes to sleep apnea because if the flows show that he does not have it, it helps determine what type of sleep apnea he is having. If he's still trying to get a breath in and we see movement in the belts but not in the flows, they call that obstructive sleep apnea. If by chance he has a decrease in his breathing and these are flat too, he's not even having effort to bring it in. They're the effort belts actually. So they'll be flat as well. And then Dr. Trev can differentiate between the 2, the obstructive or central. Central sleep apnea, you're forgetting to take a breath. Obstructive, you know to breathe. It's just not getting to your lungs. There's an obstruction. The most common is obstructive, but once in a while we will see some with the central. So that's what those, and this little guy that's on the belt is a positioner. So we know what way he's laying. So we videotape a little black and white picture. It's not huge of the bed, but we can kind of see movement in that.
Yeah.
But it'll also show on our studies which position. There'll be an S if it's supine on his back or right, because that plays too. Maybe you're fine on your right side, but on your back you
sure.
are really
Yeah.
bad. So
Sure. Okay.
so
So
they
there's,
can help.
you didn't hook up a
It's
tennis ball or anything on my.
no, Dr. Bruce used to recommend that, honestly. That was his goal if they would not wear it. He wanted them to sew a pack of their shirt
Yeah,
so they
yeah.
couldn't roll on their back.
Yeah. All right. All
I'll
right.
be
So
throwing
what's
it.
this? This is
Pulse oximetry, so we can watch the oxygen levels at night. We watch that too to determine, because some patients may breathe good, so determine oxygen protocols if they need that. Most our studies we try to run starting without O2, even if they are O2 dependent, just so we can see. Sometimes it'll mask the sleep apneas, but we do follow them and follow a protocol, and some we have to put back on.
Mhm.
But it's also good with watching those apneas. If you have those decreased flows, Dr. Trev won't just automatically say you have sleep apnea. He looks at the whole big picture, so he watches the flows. He'll look at those belts, and there has to be at least a 4% decrease in your oxygen levels. So if you're at 95, it at least has to dip down to 91 during that time. So
okay.
that
Okay.
helps determine them.
And then
I think we're to your legs.
oh yeah, I've got some stuff on my legs here too. So I got a little something going there. What's going on with my legs?
We are picking up periodic limb movements during your sleep. Sometimes patients that are restless during the night, or maybe they don't even have apnea going on, we can then distinguish if it's apnea related or is it limb movement related. We have to have a series of 4 within 90 seconds in order for it to be counted. And then the patient, we're just kind of like, if you don't have apnea going on, then something's keeping you awake at night. So we need to figure out what's keeping the patient awake so they're not getting into deep sleep. And a lot of times we find out that it is leg movements during the night that are keeping them
And
awake.
it picks up any of that muscle movement. So even if it's not a big kick, if that muscle tightens at all, it'll pick that up. Pick
Yeah.
up that up.
And you probably can see if they have really significant restless leg too, right?
Oh,
Some are
yes,
horrible. Some
absolutely.
patients
Yeah.
are.
So speaking of seeing, Liz, I'm going to have you key in up there on the wall there, and Katie or Chastity, you want to kind of talk about what Liz is filming right there?
The one on the right side, it kind of looks like a monitor and it has little white dots on it. That is actually the infrared camera. So it's going to be able to light up the room during the dark time, so we'll be able to see it. And then the top one that is above the TV is actually the camera that we're recording you with. So those are both important, so we'll be able to see the patient sleeping when it's completely dark inside the room.
Good.
And sleep time, we can turn the lights down, and I'm just gonna show for a brief second, but we also have these wall lights back here. So some patients that really like light, you can dim them. They go down
that's
as
nice.
low or
Yeah.
however too. So we do have
Yeah.
that option, or we can go total darkness as
Got it.
well. And
Okay. Yeah, very nice. So one of the things I wanted to ask you about too, and I'll probably talk with Trev about this some too, but so we're doing this. This is a study that you would do here in the hospital, and nowadays also patients sometimes will do home studies. What are we getting when I'm doing this here that you wouldn't necessarily get if I had the study done in my house? What are the pros and cons in it? Just in a thumb.
Well, I would say one of the main things that we do not see in a home sleep study would be the heart rhythm. That's important for us at night because we want to, catch anything that may be going on. So with the complete hookup, we can monitor your heart during the whole night during sleep, and then also we'll pick up those leg movements that we might not be able to get during a home sleep study. Obviously, the home sleep study only comes with 3 channels, so we can't add legs, and I don't know if the patients would quite understand how to put them on.
Right.
But I think that's another big indicator that differentiates the two.
Okay.
home sleep studies, we don't have any of the hookup on the head, so it's hard to tell the stages of sleep or if they're awake or asleep.
So, yeah. So
So
it's a
that's
more of a
kinda
crude in
hard.
that you're going to pick up if you have obvious sleep apnea,
Mm-hmm.
Yeah.
particularly obstructive sleep apnea. It's going to pick that up.
It will. It is pretty good at picking up the obstructive sleep
It's just
apnea.
not going to do such a
Um,
good job with restless leg,
anything
heart
that-
arrhythmias,
Yeah.
the sleep quality based upon some of this stuff.
That is correct. That
Yes.
is correct.
Yeah. Good to
Yeah.
know. Good to know.
Yeah.
Okay, so I'm going to try to lie down. I haven't done this yet, so let's see how this goes.
Right.
All right. So,
I'm going to hold this.
Okay.
I'm just going to hold these wires here.
all right.
Go ahead.
Oh, yes, that feels good. I'm
This
ready to go to
goes
sleep.
behind you.
Okay.
Let me take this.
Okay.
We try to keep the wires out of the way so when the patients are rolling, just like that,
Okay.
the box will follow with them and they won't get tangled up during the night in the wires.
Okay. Yeah, I feel pretty
And I put this because it's kind of heavy and bulky, so we just kind of put it here so the patients don't feel it hanging off the bed.
Okay, so if I were to try to roll over.
Yeah, go right ahead.
Okay.
It all follows you.
Yep, it should
Yeah, I
all
think-
follow and.
Yeah, I think I could do this. Matter of fact, if you guys would just leave the room, I think I'd be all right right about now. Okay, let's say here I am, and all of a sudden I'm like, oh, I think I need to go to the bathroom. So how does that all work? What do I do? Because you're across the hallway
Yes.
in the watching me. So how does that
Right.
work?
Every room has a speaker in here. I don't know if you can notice up on the ceiling there's like a little mouse looking thing. That's actually where the speaker is. So we just tell our patients at night, just speak out loud and let us know you have to go to the restroom. We're right across the hallway. We come in, we unhook one wire, which is the one back here that plugs in. And then the patient actually just carries all of this into the restroom. It's
Okay.
pretty easy.
All right, so into the restroom I go, and then come back and keep it going.
Keep it going. Yep.
All right, good.
Our beds also adjust
I'm
too
gonna
for
go ahead and
comfort.
sit.
You can put the heads up a little if you need to,
Oh,
or
nice.
they adjust kind of like a sleep number bed would, but it's the hospital grade size, so you can make it firmer, softer. And
Oh,
simpler.
wow.
So at the
Yeah.
start of the study, we usually let them get.
Kind of how you like
We
it.
encourage
Yeah.
them to sleep how they do at home. They'll say they don't always have their head up, but they can sit and watch TV a little bit. Then we try to get them to sleep their normal.
Yeah. One other question about that. So what if they sleep in a recliner at home?
That gets kind of iffy. If they're always our beds sit all the way up though.
Okay, so
we do not have
that's
a
how you're gonna
recliner in here,
simulate
but
the
we
recliner.
do. We set it up, we get them up
Okay.
to that way, because we do see that with the congestive
Yeah,
heart
some
failure
people
or the lungs.
that's just kind of their
yeah.
routine.
Well, and sometimes I'll ask the patient too, like, well, if you do have sleep apnea and we diagnose you, how would you like to sleep? You know, do you want to continue to sleep in the recliner at home,
Yeah.
or would you rather lay flat in your bed?
Yeah.
Because
Sometimes
we want to
fix
get you
them
back
and
in your
they
bed, we
can-
want to get you flat, we want to get your airways open so you can sleep comfortably.
Yeah, I remember we were talking a little bit before we went on air. One of the other advantages about doing it here is for the people that clearly have sleep apnea,
Mhm.
that during, partway through the study, you can say, oh, you know what? I think we've got sleep apnea. And then you can start the process of the CPAP machine kind of stuff. Is
So
that?
they can
Yep.
get their one at home.
Yeah,
correct.
okay. So that would be like you would say, okay, Bill, looks like you've got
Well,
it.
it looks like you qualified, Bill. So
So-
what we're going to do is we're going to start CPAP therapy with you. At that time, we usually ask the patients, do you want to use the restroom really quick? Let's get that out of the way.
Yeah.
We'll have them sit at the edge of the bed. Let's find a mask that's going to work for you. So we were looking for comfort. We want to know how you're sleeping. If you sleep with your mouth wide open, then a nasal mask is not going to work for you because it's just going to be like pumping up a tire with a hole in it. It'll go right in your nose and right out your mouth.
Yeah, that makes sense.
So we have two different kinds of masks for full face for patients that do breathe with their mouth open. And then we'll kind of work with them like, okay, let's try this one. How does it work? Are you able to breathe?
Yeah.
If they're like, oh, I don't know, then we can just swap it out and get a different one and see if it works much better for the patient.
Yeah, good.
And then titrate them once they fall
Yeah.
asleep, get comfortable, you lay down.
Sure.
Then our work starts over here. We adjust the pressures. We don't come into the room and do it patients sleeping. We can adjust it on the computer and get
Nice.
their prescription that works.
Nice. And just for folks know this, we are at the main hospital here in Sterling. So in terms of where this lab is at, that's if you had to have one, you'd go to the main hospital to check in. So anything I've forgotten to mention that you wanted to
got
add?
it all done. It's a one-night study. You usually come in that night between like 8 and 9:30. We have 2 different slots. Really quick, you sleep all night, and then in the morning, everything comes off super easy. You're usually out of here by 6:30, 7:30 the latest, and
Yeah.
Dr. Treviranus follows up the very next day, comes in, takes reports, and then he'll dictate, and
Yeah.
depending on what was done, he writes a prescription and gets that going for the CPAP or,
Okay.
so yeah, in
Good.
and out in one
Yeah.
night.
Katie, Chastity, thank you very much.
you.
You're
Appreciate the
welcome.
work that you're doing. This has been really interesting for me. I mean, in many ways, it's been really interesting for me. And I hope for those of you who are watching it, it's giving you some more good information about sleep studies and how that works here at CGH. Until next time, thanks for watching.